Imagine battling a chronic, agonizing pain condition for literally decades.
It's exhausting just to think about.
Right. And you're told over and over by doctors that the ultimate finish line is menopause. Like, once your periods finally stop, the disease will just kind of miraculously turn off.
Which is such a common narrative.
It is. You wait for that supposedly magical cure, only to discover that the menopausal transition might actually act like, well, throwing a bucket of gasoline straight onto your symptoms. Welcome to the deep dive.
Thank you. Yeah, that paradox is, it's honestly one of the most frustrating and poorly explained realities in women's health today.
Because we assume a biological off switch exists.
Exactly. And assuming that off switch exists creates these incredibly dangerous medical blind spots for anyone trying to navigate it.
So today, our mission is to map out this exact intersection. What really happens when endometriosis or adenomyosis collides with the menopausal transition?
And it's a messy collision.
It really is. So to untangle this, we are combing through clinical standards from the British Menopause Society, the NHS, the UK's NICE guidelines, which set the national standard for clinical care, along with some fresh data from leading specialty clinics.
Because understanding how to manage this, especially when you bring hormone replacement therapy into the picture, it requires walking this precarious biological tightrope.
And it seems like it requires an entirely different clinical playbook, right?
Oh, absolutely. The standard generalized advice for menopause completely falls apart when you apply it to patients with these specific conditions.
Okay, so since anyone dealing with these conditions already knows the agonizing difference between endometriosis lesions, seated throughout the pelvis, and adenomyosis buried deep inside the uterine muscle wall, let's just bypass the basic anatomy for a second.
Good call.
I want to use a house analogy to frame this. If the uterus is a house, endometriosis is like the wallpaper growing on the outside of the house on the ovaries, fallopian tubes, bowel, while adenomyosis is the wallpaper growing directly inside the actual brick walls.
That's a perfect way to visualize it, yeah.
But since they are such similar tissues, do people often have both? What really stands out in the clinical data is the overwhelming overlap, right?
It is wild. Historically, doctors treated them as totally separate diseases, like completely isolated.
Which makes sense based on where they are geographically.
Right, but looking at the latest advanced imaging data, that assumption is just being completely blown out of the water. The shift in our diagnostic understanding has been massive over the last few years.
Tell me about that German MRI study, because the numbers there were staggering.
Yeah, so there was a pivotal study out of Germany that looked at the pelvic cavity in high definition. And they found that 80% of patients with adenomyosis also had endometriosis.
Wow, 80%.
And it gets crazier. A massive 91% of those with endometriosis had adenomyosis.
Wait, 91%?
91%.
That practically means if you have one, you should be treating your body as if the other is already in the room, or at least, highly suspecting it.
It completely changes the diagnostic baseline. If a clinician is only looking for one, they're almost certainly missing the other.
Right.
And while they present differently geographically so, adenomyosis causing that bulky, enlarged uterus and intense pelvic pressure, while endometriosis causes profound cyclical pain and potential bowel or bladder involvement, they share the exact same physiological engine.
Estrogen.
Exactly. Both conditions are entirely driven by estrogen.
Estrogen is the fuel. It tells the ectopic tissue to thicken, break down, and bleed.
Yeah, and because that tissue isn't in the right place, the blood has literally nowhere to go.
Sparking intense local inflammation, which, brings us to the core conflict of this deep dive. If estrogen is the fuel, and menopause is essentially the depletion of that fuel.
Where are you going with this?
Well, shouldn't symptoms just quietly fade away during perimenopause? The common assumption is that you're slowly running out of gas, so the engine should just quietly power down.
Oh, man. That assumption fundamentally misunderstands what perimenopause actually is.
It's not a gentle decline.
Not at all. It is not a gentle, graceful decline. Think of it more like a faulty thermostat connected to a sputtering engine.
I like that visual.
So your brain is screaming at your ovaries to produce estrogen, but the ovaries are struggling to respond consistently. So instead of a slow fade, you get these chaotic, massive estrogen surges.
So you aren't just slowly losing estrogen, you're actually getting hit with erratic tidal waves of it before the system permanently shuts down.
Exactly. And the crucial mechanical piece of this is ovulation. During perimenopause, which, by the way, can drag on for up to 10 years.
10 years.
Yeah, up to a decade. You are frequently having anovulatory cycles, meaning you don't actually release an egg.
And why does the egg matter for the pain?
Because if you aren't ovulating, you aren't producing progesterone. And progesterone is the hormone that normally counterbalances estrogen. It's the hormone that thins the lining and calms the tissue down.
Oh, wow. So the brakes are essentially out and the accelerator is stuck to the floor.
That's exactly it. You have these massive surges of estrogen, completely unopposed by progesterone. The local inflammation goes into absolute overdrive.
So for the patient, this must mean active, aggressive flare-ups, right?
Horrible flare-ups. Cycles might suddenly shorten, dragging the pain closer together. The adenomyosis bleeding can become dangerously heavy.
And I imagine endometriosis lesions on the bowel or bladder just become wildly aggravated by that unopposed estrogen.
They absolutely do. And the real tragedy here is what happens when someone in their early or mid-40s takes these escalating symptoms to their doctor.
Oh, I can guess. They're bleeding heavily, they're in absolute agony, and the clinician just brushes it off.
Well, your periods are just changing. It's normal perimenopause. You just have to tough it out.
It's infuriating.
It is. The clinical guidelines we are looking at today emphatically state that this is not a normal transition for these patients.
It's an active disease flare.
Yes. It's a severe disease flare driven by a hormonal storm. Dismissing it denies the patient targeted medical management during one of the most vulnerable physiological windows of their entire life.
Okay, so that natural fading or sputtering of estrogen is one thing. But let's say a patient survives that sputtering engine phase. The fuel finally runs out.
They hit the finish line.
Right. They reach actual natural menopause, which is defined biologically as 12 full months without a single period. The ovaries have officially retired. Is the patient completely in the clear then?
Well, the cyclical production of estrogen stopping is generally very good news. Without that hormonal stimulation, the ectopic tissue essentially goes dormant.
So the heavy bleeding stops.
Usually, yes.
Yeah.
The active heavy bleeding of adenomyosis stops, and that distinct period-driven cramping usually fades away.
Right.
And this is a big, but the physical footprint of the disease remains.
Because the architectural damage to the pelvis hasn't just magically been erased.
Right. The lesions might be inactive, but the scar tissue, the adhesions binding organs together, the bulky muscle wall of the uterus from the adeno, that structural aftermath is still just sitting there.
So many individuals will still feel pelvic pressure or pulling sensations simply due to those adhesions or the persistently enlarged uterus.
Exactly. But there is a massive clinical red flag we have to emphasize regarding this dormant phase.
Which is?
Because the tissue is inactive now, any new or postmenopausal bleeding is highly abnormal.
Okay, so you can't just assume the old adenomyosis is acting up again.
Never. You can never assume that.
Sure.
Postmenopausal bleeding must trigger an immediate clinical investigation, usually an ultrasound, and an endometrial biopsy to rule out endometrial cancer.
Okay, let's tackle the cancer risk, honestly, because that word alone is a huge anxiety point for anyone with chronic pelvic disease.
Understandably so.
What do the data actually tell us about malignancy risk for these two conditions once you cross the menopause threshold?
Looking calmly at the long-term data, adenomyosis is overwhelmingly benign.
Okay, that's reassuring.
Very. The transformation rate into a malignancy is extraordinarily rare, around 1%.
And what about endometriosis?
Endometriosis requires a slightly closer watch. It isn't the cancer itself, obviously, but it carries a documented, albeit modest, association with an increased risk of specific types of ovarian cancer down the line.
Like which types?
Specifically the endometrioid and clear cell histotypes. This is why any new pelvic masses or sudden return of severe pain in menopause needs specialist evaluation rather than just a wait-and-see approach.
Right. Don't just ignore it. So that covers the natural pathway. But many patients, they can't wait out a 10-year perimenopausal storm. They are forced to pull the emergency brake, chemically or surgically inducing menopause overnight.
Yeah, induced menopause is a whole different beast.
What does that free fall do to the body?
Well, induced menopause is a sudden, total halt of ovarian function. This can be surgical through a bilateral oophorectomy, meaning removing both ovaries to definitively starve the pelvis of estrogen.
Or it's done with drugs, right?
Right, pharmacologically using medications called GnRH agonists or antagonists. We're talking about drugs like linzagolix or relugolix.
Let's pause on the mechanism there. How do those drugs actually switch off the ovaries?
So they interrupt the chemical communication between the brain and the ovaries. The brain normally sends gonadotropin-releasing hormone, or GnRH, telling the ovaries to make estrogen.
And the drugs block that?
Exactly. They block that signal. The ovaries stop receiving the message, so estrogen production plummets to postmenopausal levels within a matter of weeks.
Flipping that switch overnight means the body must go into absolute shock. I mean, you're bypassing the 10-year transition and just jumping off a physiological cliff.
It is brutal. The onset of menopausal symptoms is severe and immediate. Patients experience intense, debilitating hot flushes, massive bone density loss, rapid acceleration of cardiovascular risk,
Severe brain fog, I'd imagine.
profound brain fog and mood shifts. The body is suddenly deprived of its primary protective hormone.
Which brings us to the ultimate medical paradox of this whole deep dive. If someone is suffering from these intense menopausal symptoms, whether natural or induced, they desperately need hormone replacement therapy.
They do. They need estrogen to protect their brain, stabilize their mood, and keep their bones from crumbling.
But wait, we just spent this whole time establishing that estrogen is the literal fuel that feeds endometriosis and adenomyosis.
Yep.
Taking HRT sounds like pouring gasoline on a fire you just spent years trying to extinguish. How do doctors safely prescribe it?
Navigating that paradox requires immense precision. You can safely prescribe estrogen to protect the brain and bones, but there is a non-negotiable rule in the guidelines. You must deploy what we'll call the progesterone shield.
The progesterone shield. I want to dig into the mechanics of this because standard HRT for someone without these diseases often just involves taking estrogen, right?
Unopposed estrogen.
So for our group, how does the progesterone shield actively protect the pelvic cavity?
In clinical terms, it's referred to as continuous combined HRT, or CCHRT. Every single day that you take estrogen, you also take a continuous dose of a progestogen.
Like oral micronized progesterone.
Yes, or the localized release from a Mirena intrauterine device. At a cellular level, continuous progesterone actively downregulates the estrogen receptors in the ectopic tissue.
Downregulate. So it essentially makes those rogue endometriosis cells deaf to the estrogen you were taking.
That is a brilliant way to put it. Yes, it makes them deaf. It keeps the disease suppressed, while your brain and bones still reap all the systemic benefits of the therapy.
That's fascinating. You're giving the rest of the body the estrogen it needs while putting earplugs in the endometriosis cells so they don't respond to it.
Exactly. But here is where it gets tricky. What about patients who have had a hysterectomy?
Well, standard medical dogma says if the uterus is gone, you don't need progesterone because there's no uterine lining left to protect from estrogen-driven cancer.
Right. But this is one of the most counterintuitive, yet absolutely vital rules laid out by the British Menopause Society. If a patient has had their uterus removed, but they have a history of widespread endometriosis, they absolutely still require the progesterone shield.
They should be given combined HRT, not estrogen alone.
Yes.
Because the endometriosis lives outside the uterus.
Precisely. Even with the most meticulous excision surgery, microscopic residual disease can be left behind on the bowel, the bladder, or the pelvic sidewall.
And if you introduce unopposed estrogen into that environment,
You risk waking up that residual disease and plunging the patient right back into chronic pain, or theoretically promoting malignant transformation of those cells over time.
wow. So the continuous progesterone keeps that microscopic battlefield dormant.
It is non-negotiable. And looking at the guidelines, they're actually ruthless about what kind of progesterone actually works for this shield. They explicitly call out several popular alternatives as dangerous.
Like the compounded bioidentical hormones.
Yes, they strongly warn against compounded bioidenticals. These are mixed in boutique pharmacies, they're completely unregulated by standard medical bodies, and there is zero clinical evidence that they deliver an adequate standardized dose of progesterone to actually protect the tissue.
Okay, but what about transdermal progesterone? You see creams and gels heavily marketed online as a natural, gentle alternative to pills.
The clinical nail in the coffin for transdermal progesterone was a major study called the ELITE trial. It demonstrated definitively that absorption through the skin is highly erratic.
So the levels of progesterone in the actual tissue fluctuate wildly.
Exactly. That means the shield is full of holes, leaving the ectopic tissue vulnerable to estrogen stimulation. You have to rely on properly regulated, adequately dosed oral progesterone or a progestogen-releasing IUD to maintain that steady receptor downregulation.
Okay, but even with the perfect evidence-backed progesterone shield, human biology is messy. What happens when a patient starts continuous combined HRT and their body flares up anyway? Do they just have to choose between the systemic misery of menopause or the agonizing pain of a disease flare?
It's a huge fear, but a flare-up on HRT is actually quite common initially. But it is a signal to adjust, not to abandon ship.
How do you adjust?
The first clinical move is often to increase the dose of the continuous progesterone to strengthen that shield. The guidelines emphasize that initial bleeding and pain typically settle within 3 to 6 months as the body adjusts to the steady state of hormones.
But if adjusting the dose doesn't calm the flare, the sources highlighted a fascinating pharmacological alternative called tibolone.
Yes, tibolone is incredibly unique.
From a mechanistic standpoint, how does one drug manage to replace a combined HRT regimen?
Well, it is a synthetic steroid, but once it enters the body and metabolizes, it essentially breaks into 3 different compounds. It provides estrogenic, progestogenic, and weak androgenic activity all at once.
Androgenic activity, meaning it mimics testosterone.
Yes, which is fantastic for managing menopausal fatigue and low libido. But crucially, because of how timolone specifically acts on the tissue receptors, it is actually licensed and proven effective for patients with a history of endometriosis.
Really?
Yeah, it offers systemic menopausal relief with a much lower risk of hyperstimulating the pelvic cavity compared to traditional estrogen therapies.
It's a huge tool to have in the arsenal. And, if a patient's main menopausal symptom is isolated, like severe genitourinary symptoms, vaginal dryness, or pain during sex, they don't even necessarily need systemic HRT, right? The sources note that localized vaginal estrogen is perfectly safe.
Because the dose is so low, it's applied directly to the vaginal tissue, so it doesn't absorb into the systemic bloodstream in high enough concentrations to wake up adenomyosis or endometriosis higher up in the pelvis.
So it solves the local problem without triggering the systemic disease. Let's shift to the physical realities for a second. Because medications and receptor downregulation can only do so much. When the disease burden is just too high or HRT flare-ups become totally unmanageable, what are the surgical interventions during this transition?
So for endometriosis, the absolute gold standard remains excision surgery. Not ablation, not burning the surface, but meticulously cutting out the root of the lesions from the surrounding organs.
And removing that disease burden makes introducing HRT vastly safer later.
Vastly safer, yes. For adenomyosis, because the disease is literally woven into the muscular wall of the uterus itself, a hysterectomy is the definitive cure.
But for patients who want to avoid major organ removal, there are other interventions. What about uterine artery embolization?
UAE is a very powerful alternative to a hysterectomy. An interventional radiologist essentially blocks the specific blood vessels feeding the uterus.
And by cutting off that blood supply, the adenomyosis tissue shrinks.
Exactly, which dramatically reduces the heavy bleeding and pressure.
Now, I really want to talk about endometrial ablation because this is where the mechanics of these diseases become incredibly important.
Well, this is crucial.
Right, so ablation burns away the inner lining of the uterus to stop heavy bleeding. But if adenomyosis is a disease where tissue is buried deep inside the muscle wall and you use ablation to just burn the surface lining, aren't you essentially just paving over a sinkhole? Like you're trapping the bleeding inside the muscle.
That is a brilliant way to picture it, and it's precisely why clinical guidelines explicitly warn against ablation for adenomyosis.
You were sealing off the surface with a thick wall of scar tissue.
Exactly. Which means the adenomyosis trapped beneath that scar tissue continues to swell and bleed every single cycle, but now the blood is literally blocked from exiting.
That sounds horrific.
It leads to severe localized swelling and can make the intense cramping pain exponentially worse. It's a procedural trap, and it reinforces why getting a precise diagnosis, knowing whether the disease is seated outside the organs or buried deep within the uterine muscle, dictates every single step of your care.
It dictates the scans you get, the exact pharmacological makeup of your HRT shield, and which surgical interventions will save you versus which will actively harm you.
Perfectly said.
So to bring this all together for you listening, the menopausal transition, whether it's the chaotic 10-year perimenopausal sputtering engine, natural menopause, or the sudden free fall of surgical menopause, is not an automatic off switch for these conditions.
No, it is a highly volatile hormonal shift that demands vigilant, tissue-specific management.
It means pushing back when a clinician dismisses your perimenopausal pain as a normal transition.
It means strictly adhering to the progesterone shield to downregulate those ectopic receptors, ensuring that your HRT protects your brain and bones without reigniting the pelvic fire.
You have options. You can tweak hormone ratios, explore metabolic alternatives like tibolone, and leverage precise surgical interventions. You do not have to accept the false choice between the agony of your disease and the systemic devastation of menopause.
Provided you are working with a specialist who actually understands the complex pharmacology of both.
Right. Which leaves us with a final thought to ponder as we wrap up this deep dive. We've spent this time discussing the fairly blunt tools we currently use to navigate this tightrope, right? Surgically removing entire organs or deploying sweeping whole-body hormones to either suppress or replace estrogen.
Blunt instruments, for sure.
But knowing what we do now about how deeply specific these ectopic cells are, how they uniquely respond to hormonal cues, how might the next frontier of medicine look?
That's the million-dollar question.
Could the future lie in targeted receptor modulators? Imagine a treatment that acts exclusively on the ectopic cells in the pelvis, shutting down their estrogen receptors permanently while leaving the rest of the body's protective estrogen perfectly intact to run the brain, the heart, and the bones.
A therapy that targets the exact ZIP code of the disease without disrupting the whole biological city. That truly is the holy grail of gynecological pharmacology.
The days of assuming a straight line in women's reproductive health are over. The diagnostic waters might be murky, but by understanding the cellular mechanics of your hormones, the geography of the tissue, and the non-negotiable rules of HRT, you don't have to drown in them. You can navigate your way through.
With the right clinical map, absolutely.
Thanks for diving deep with us. We'll catch you next time.